All right. Hi, everyone. My name is Meredith Shiner. I'm a director at the UChicago Urban Network. The Urban Network is a collection of more than 24 entities across the University of Chicago's campus. And we're focused on highlighting and lifting up voices across our campus community who focus on urban scholarship, policy, and practice. It's a great honor to host this conversation today. And hopefully, if you like it, we'll be having others later this quarter, so stay tuned for that. But we're really delighted to have such a prominent and smart group of women and leaders in healthcare on this conversation today to talk about racism as a public health crisis, especially as it relates to COVID-19 and vaccination and where we can go from here. Obviously, over the past year, some of the conversation nationally has really shifted to grappling with systemic racism and how it impacts Americans across the country and especially in Chicago. And nowhere has that been more evident than in healthcare. So it's a great privilege and honor to introduce our panelists and our moderator today and to get this conversation started. Dr. Candice Robinson is medical director for the City of Chicago's Department of Public Health Communicable Disease Program. She's a board certified pediatrician and previously served as a medical officer within the Centers for Disease Control and Prevention. Brenda Battle is one of our leaders at the University of Chicago. And since our last conversation with her, I'm delighted to inform everyone that she's been promoted into the Senior Vice President of Community Health Transformation, and as well as being the Chief Diversity, Equity, and Inclusion Officer at the University of Chicago Medicine. Dr. Arshaya Baig is an Associate Professor of Medicine and a board certified internist at the University of Chicago Medicine who specializes in treating patients with diabetes. And our moderator today, who I will hand this off to now, is Natalie Moore. She's a reporter at WBEZ, Chicago's NPR station, and she focuses on race, class, and communities, covering segregation and inequality, with a special focus and expertise on the South Side of Chicago. So again, thank you all for coming to this conversation today. It's really important to have now, but it's also really important to continue to have. And so the Urban Network is committed to continuing to focus and host these sorts of conversations. So with that, I hand it over to Natalie.
Good afternoon, everyone. Thanks so much for spending your lunch hour with us. And I am excited to have this conversation. But before we get started, I've been doing so many Zooms, and this is a question I start off with a lot of people. But since you all are, on the front line of this work, how are you doing in this past year? How are you, not just the pandemic, but all the, the racism that's coming with it. And, there's just so much that's there. And Candice, I imagine that you probably just don't have any vacation days until 2023. So yeah, just how are each of you doing?
I'll start. It's been a busy time. We've obviously, we don't shut down hospitals and health systems. Matter of fact, we've needed them even more during this time of COVID. And, a lot of our work has continued, but it's also pivoted to how we help our community to survive and get what they need during this time of COVID. So we spend really long days getting the work done that we naturally do, but also, working to make sure we're taking care of the communities that we serve. So I'd say we're probably all tired, but we're also motivated because we think that, in my opinion, this COVID, what we've seen in COVID and what we've all known for a long time and that others now are aware of, has, I think, inspired some activity that motivates our work and enables us to not have to convince people that issues of racism and health disparities and health inequities exist. They exist. People know that now. So there's a light at the end of the tunnel, but I have as much energy as I have tiredness. Let's put it that way.
Yeah, I would 100% agree. It's a very busy time, but I think it shows the importance of health, of our health systems, of public health, and it has highlighted these disparities that we know have existed for quite some time. But I think COVID has kind of shined a light on them in a way that maybe many hadn't seen before. And so I think it's kind of the recognition that it's there. And COVID has highlighted this, as Dr. Battle said, there's a light at the end of the tunnel, but there's also going to be a lot of work to do after this to continue to address kind of all of the things that have led to where we are today.
I will echo everything that Brenda and Candice have spoken about. I think the word of the year is perseverance for me, and that light at the end of the tunnel. I'm a fairly optimistic person. I think that things are going to get better. I think that the pandemic has brought some changes that we needed in terms of more telemedicine and reaching out. I think it has, again, brought to the forefront some of these disparities that many of us know have existed, but now the conversation is elevated. There's opportunity to do more, think more, act more. I think also in just taking care of our patients, our communities, my trainees, thinking about what is happening. We're having these active discussions, even with my family, school teachers, right? I mean, we all have families too, right? We're living through this pandemic as healthcare providers and working in a healthcare system, but also personally with our children and family and friends.
Recent polling has shown that there was an initial media narrative around the vaccination that Black and Brown communities were hesitant. But what we have found is that the most vaccine hesitant population is actually Republican men, by more than double of Black Americans. Can each of you speak to the differences in vaccine access and vaccine hesitancy or acceptance, and how that varies by population here in Chicago?
Yeah, sure. I think there's certainly some things that we've been kind of looking at around vaccine acceptance in all communities in Chicago. It's going to be, very important as this vaccine rolls out that we have high acceptance amongst all. But I also do think it's important that we recognize that sometimes it's not hesitancy and sometimes it's access and access issues. And so one of the things we really have to work and strive to do, and one of the things we've done kind of in the process of the vaccine rollout, is to kind of, how can we make this vaccine more accessible? How can we make it accessible to the people who, can't easily drive across town to get a vaccine dose, or the people who can't sign up for vaccination on their phones or via computers. So definitely the access plays a large role in vaccination as well, in addition to vaccine acceptance, and that cannot be minimized at all.
And I'll just add that, early on, I think that the hesitancy was greater. And the assumption was, the hesitancy was based simply on some of the historical research that we know about in the past. But, issues about safety and the efficacy of the vaccine, those things came out. Some of that was, related to just the political environment and how fast the vaccine was created. We've done a lot of work to help people to shed light and understand that. But the hesitancy in Black and Brown communities had, there are a lot of factors that influenced that hesitancy early on. Some of the historical issues around, structural racism, some of the decisions that were made in communities like redlining. And there are a number of factors, the distrust of the healthcare system that led to the hesitancy. And I think there's been a lot of work to create opportunities for community members to understand some of the facts about the vaccine. And so some of that is actually dying down. And as you see, there's a focus on equity in the delivery of the vaccine. We're seeing less hesitancy, but more people in communities that, Black and Brown communities at least, that were more hesitant in the past, since they're seeing greater access, being willing to get the vaccine. So we see that diminishing. It is an access issue. There's just not enough vaccine on the streets right now for the people who want it. There are a bunch of people who are showing up for some of these events and getting the vaccine that were previously assumed to be hesitant. So I'm not sure about the data. I mean, well, the data that you just showed us, I was surprised when I saw the data on the the most hesitant population being white Republican men. And I don't know what those reasons are. You know, they could be related to some of the politicizing of the vaccine issue. I don't know, but I know that we're seeing some shifts in Black and brown communities. And I think the more access we have to vaccine, the greater participation we'll see in getting the vaccine.
And just a quick follow-up to that, Brenda, do you think it's because more people are getting the vaccine and they're seeing other people get it and they feel a little more relieved? Or is it, okay, I want my life to get back to whatever normal was, I'm willing to take it? Have you been able to identify any of the reasons?
I would say it's both, and maybe Dr. Baig, you can respond to it as well, but I think it's both that, you know, the fear of what's going to happen to me when I get to the vaccine, that's dissipating because so many people are getting it and nothing's happening to them. And then the other is, you know, it was a little bit of a wait and see for a minute for some folks. Let's see what actually happens. And then now it's, look, I want to get back to some, you know, I want to hug my loved ones. It's all of that.
Yes, I'm going to echo everything that Dr. Robinson and Brenda are speaking about. I think, you know, in the Latinx communities, what we're seeing is that, yeah, it's an access issue. You know, Kaiser Family Foundation came out with a survey just in the past few months that more than 70% of Hispanics in the US want the vaccine. Now, when we disaggregate, you know, by age and if they're essential workers or not, we do see some difference even within the Hispanic community. But I think, you know, if someone more than 70% of a community wants something, I don't think that's hesitancy. I think that they want it. I think some of the issues in terms of access have been also language. So are we providing the information about the vaccine and the signups in Spanish, right? Well, Dr. Robinson talked about the technology issues as well, in terms of access to internet and the Wi-Fi and the smartphone. I think that having more, so many Hispanics also work in essential service industries. So I think there's this desire I need to get vaccinated so I can continue working, and then also to protect my family.
And a follow-up, can you talk about the work that you're doing in Little Village and how some of those barriers are being broken?
Yeah, so I have a community advisory board that I have been meeting with, oh gosh, for almost a decade now, to inform the work I do, mostly around diabetes interventions, but just really health disparities in Latinx communities. And in speaking with them, there's lots of like pop-up events, right? Like the health centers are getting vaccines actually through the Chicago Protect Plus program. The churches are getting involved, the local pharmacies are getting involved, the community hospitals. So it's great. I think when there is vaccine, these entities are ramping up to be able to provide, right? Which is great. But to me, these are like lots of pop-up events. There's this event, there's that event. There's no structured, like, here you come every day or every weekend and you can get your vaccine, right? It's like, it's almost like a race, like, oh, this church just opened up, let's fill it. And like within minutes, the slots are filled up, right? And then also working with our agencies, they have to ramp up their staff. You know, I mean, I work with health centers across the Midwest and I'm in a current trial. And each time we meet, they're telling me like, oh, we couldn't work on your project just this month because we're doing COVID vaccines, we're doing flu vaccines. So they're getting pulled away from other things. So it's great that we have vaccine supply, but we also need to support the health centers, the small agencies, the pharmacies, all the people who are actually on the ground and giving the shots.
Right before we went live, I saw my sister texted me a piece in the Washington Post. I didn't get a chance to read it yet, but it said, friendships are being tested friendships are suffering because some friends don't like that their friends are lying to jump the vaccine line. And we know that there is a degree of privilege that happens with that and who is jumping. And if they're not jumping, we're seeing that, you know, white people are still getting vaccines more. I'll be on text threads and I'll have someone say it's a bunch of white people in Roseland Hospital right now getting vaccinated. how is this? I'll start with you, Dr. Robinson. How can jumping the line, especially when it comes to race, be addressed with vaccine access?
Yeah, I think that's one of the things, that when we started Protect Chicago Plus, which Dr. Bayek kind of mentioned briefly, the goal was to really try to get vaccine in the community and limit the access to the community members. So a little bit about Protect Chicago Plus. It's really a program that the city of Chicago began. We really looked at the neighborhoods that had the most burden from COVID. We looked at a number of factors, social factors, unemployment in the neighborhood, access to providers in the neighborhood, insurance coverage, amount of underlying conditions in the neighborhood, and then COVID burden indexes as well, to really see kind of what are our neighborhoods that have been most burdened by this pandemic. And all 77 neighborhoods in Chicago were kind of listed out. And for those top 15 neighborhoods, we instituted this Protect Chicago Plus initiative. And really, it's really working with community members, working with the community-based organizations in those areas, working with the providers in those areas to bring in community members. And we actually have, maps where we draw out, this is the community where we're drawing from. And we invite in people to those clinics that were mentioned earlier, to those temporary clinics that are in the community, specifically from that area. And, you must live here to get this vaccine dose. And I think kind of one of the ways to address that is, as we can get vaccine in community and work with the organizations to bring in the community members, then you can give access to people kind of in their area without, having people who from outside of their area come in to be vaccinated at those events.
And I have to ask you, because it's just in the news every single day, Loretto Hospital, what are your thoughts about what's going on there? And what will the public health department do to try to make sure that there aren't other violators like that?
And we continue to work with our providers, continue with our provider messaging. We continue to work with Loretto. And, we are continuing. There is Protect Chicago Plus going on right now in the Austin community. And we've picked up and continued that as well to continue vaccine access as well. So, we'll continue working with our providers. I would say, our providers are, by and large, very invested in this. We have partners from all over the city engaged in this Protect Chicago Plus work, and they've been very invested and excellent partners. So we'll continue to partner with our providers on these initiatives.
I would just say that we are working with a health center in Roseland this weekend, standing up one of the pop-up clinics. They run for a period of time, so they're not a day. Some of the events are a day and then they're gone, but the temporary clinics are actually over a period of time. So starting this Friday, we'll be staffing and supporting a clinic that's running for 6 weeks, 3 weeks for the first dose and 3 weeks for the second dose. We've made it really easy for people to register. We know that people will walk in and we have a system to handle that if that happens. We do want folks in that community to be the persons getting the vaccine. So you have to verify that your address was within the neighborhoods of Roseland and Washington Heights for this particular clinic. But those are the same types of clinics that we're seeing all over Chicagoland. And there has been an incredible uptake of persons in that community, in those communities getting the vaccines. And Dr. Robinson, you can respond to this, but some of the early temporary clinics, the numbers of percentage of persons in those communities are now matching what we're seeing on the north side of Chicago, where, early on, it was a lot of people on the north side of Chicago that were getting the vaccine, but some of those numbers are actually matching that.
Yeah, absolutely, Dr. Battle. We have been seeing results of this approach to bringing vaccine in community and to prioritizing certain zip codes for vaccine access. So another thing you may have noticed is for the United Center, there have been kind of prioritization on zip codes for vaccination at the United Center. And so kind of two of our three top zip codes for vaccination right now, one is a Protect Chicago Plus community, and one is a community that was prioritized for vaccination through the United Center. And so these efforts are working. These partnerships and these investments in the equity work are working, and we're seeing that in the data in terms of who we're seeing vaccinated in the areas that our vaccination rates are quickly rising and matching other areas of the city and beyond.
Yeah, I will say I feel like we're learning our lessons and we're improving. Again, I'm very much an optimist, so I see what was happening even in Little Village when there's this one clinic that opened up their list, and there's a lot of people from not the neighborhood who signed up. But that was a lesson learned. And now, we are verifying addresses or, and moving forward and actually vaccinating the people within that neighborhood. So I think for me, it's been a year of change. We're learning a lot, right? We're rapidly adapting. And I think as we see inequities, I'm seeing that we're trying to address them, and that's from CDPH guidance and also ID, the Illinois Department of Public Health. So I do think things are improving.
And I'd just like to add that UChicago Medicine, we sit on the south side of Chicago. 77% of the population is African American, 12% is Latinx. And we early on stood up a vaccine allocation committee focused on equity. So when we started distributing according to the phases that were laid out from CDC and passed down to us through Chicago Department of Public Health, we had equity as the primary focus of who was getting those vaccines. So if it started with our patients or it moved to essential workers, it was really focused on who are in these zip codes that we're serving that are our primary community, and ensuring that the individuals in these community got the vaccine. And so we have a high number of in terms of equity, diversity with our patient population to ensure that we were getting vaccines in the arms of the most vulnerable populations that were affected not just by COVID, but predisposed conditions that they had that were already experiencing health disparities, that we were addressing those patient populations and ensuring that we were getting vaccines. And there was a willingness to get it. So we've had a focus on equity, really proud of Chicago and its focus on equity, but we at UChicago Medicine, we've had a focus on equity as well from the beginning.
You all have mentioned that you learn as you go along, and I mean, this is not something that we have been through before, but what else would you say you need either personally or institutionally or from the government to keep getting those numbers to be higher in Black and Brown communities?
Well, I think this pandemic has highlighted kind of the importance of investment in public health infrastructure, in health infrastructure, in access to care. And I hope, if nothing else from all of this, that, we continue to kind of see those investments. We continue to see people recognizing the importance of health systems, recognizing the importance of public health, and continuing to provide the resources needed so that we can continue to address these inequities, but also just kind of build up our systems over time as well. So I think, people are seeing this as an opportunity that, we've highlighted some of these issues, and now this is our opportunity to really invest and to really make the changes and the investment in the people, the resources, et cetera, that we need to kind of address these issues and continue to improve health well beyond this pandemic.
I think that some of the other things that we learned is it hasn't been the historical practice that public health has worked with private health. So public health hasn't typically worked with academic medical centers, some of them if there's some research, but not in a public health endeavor like this. And so I think this has brought healthcare systems, academic medical centers, safety net hospitals, and FQACs together with public health to address this issue. We hadn't done it to this magnitude and scale before. We've done projects, but not to this magnitude and scale. So I think it's highlighted that, the delivery system working together can actually get some things moved fairly quickly. I think the other thing that we've learned is we've got to be close to the boots to the ground. We got to get close to the folks in the community who, and leverage the resources in those communities that have more, or more trusted than we are. People don't trust academic health. They don't trust public health. They don't trust the healthcare system. And so we have to be close to the ground. We have to be there with them in the community where they are. We have to leverage their trusted messengers, leverage the assets that they have within the community, and work alongside them to address these broader public health concerns. So I hope we learned that we've got to continue to do this, and we can't let the pandemic pass and then stop doing that, that this is essential that we continue to work alongside community to address these issues.
Yes, 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 and yes, Brenda. I'm a community-based researcher, so I actually partner with organizations, churches, health centers, nonprofits in doing my research, because exactly that. There are so many resources in what we say underserved communities, but they're rich with churches and nonprofits and organizations and just people, community activists, community members who want to help. The efforts that I see in Little Village in terms of getting the vaccine out, partnering with one of the biggest Catholic churches there, right? People trust the church in that community. Partnering with the local pharmacies. They may be big chains, but it's actually the local pharmacists who are going out and making these connections with the churches. It's the health centers that are rooted there, that know how to deliver care, how to do the messaging in Spanish, setting up the phone line. They understand the community. So I think that working with grassroots communities is important. And, Natalie, going back to your question, what can the federal government do? Also, I think trust is a major barrier, especially in immigrant communities. Even at like the Chicago Department of Public Health, and I think the Illinois Department of Public Health websites, there's like a disclaimer that says you can come get tested and don't worry about us giving your information to ICE. And it made me sad to think that we have to put that on the website, but it made me realize, we actually do need to do that. We need to let people know that, come get tested. Please don't have fear of us sharing your information or your immigration status. So that's maybe particular to this community, but particular to many immigrant communities probably across the city.
Natalie, if I could say, I hope that we all learn that because we don't live in these communities doesn't mean we're not impacted by something like this. We're going to have some devastating effect on our economy, our state and our city economy just across the country because of COVID. People lost their jobs, people are losing their houses, people are unstable, people are suffering from, depression and the issues of mental health. And that's not just going to impact the people who are in vulnerable communities. That's going to impact all of us. So the assumption that because I don't live in these communities, I don't live like this every day, this doesn't affect me is erroneous. So if we don't all get involved in addressing the changes that are necessary to create equity in our system and get rid of these structural issues that have impacted people's lives forever. These things are going to impact all of us and not just the people who we think are suffering the most. So I'm hoping and praying that we all learn that lesson as well, and that we have much more engagement and activism around addressing these issues so that if one of us does better, we all do better and get out of the mindset that it's them and not us.
One of the things that the pandemic has exposed is systemic racism in just about every sector. I can't think of one area that hasn't been touched. And as people start thinking about normalcy, it's really about how can we reimagine being better. And when it comes to healthcare, out of all the lessons that have been learned, out of what you all have experienced, as a provider or as a partner, what needs to be done going forward to make sure that there's less racism in healthcare, as well as more trust? Because, it might be another 100 years from now, but there'll be another pandemic and people will look back and see what happened in the early 2020s.
Well, yeah, I think the first thing is, like, we just can't stop at the pandemic. You know, when we do get back to whatever new normal will be, we can't just say, oh, well, job well done, we're done, you know, time to move on to the next thing, and get so back to normal that we don't address kind of all of the underlying issues that led us to COVID and led us to the inequities we saw. I think, you know, one of the things is just kind of continuing to look forward, and how do we address these structural things beneath all of what we've seen come out through COVID. You know, one thing, the city launched Healthy Chicago 2025 at the end of last year. And really it's a 5-year plan that seeks to address kind of these social conditions and other factors that have really been created by decades of the segregation and systemic racism, and, you know, that have these effects of which have been highlighted in COVID-19. But there are things that underlie that have been come shown light. You know, there's quality healthcare that needs to be addressed, and quality housing, food access, creating safe spaces for all Chicagoans to live and work and play. You know, all of these things will be very important to continue to address after this pandemic. And so continuing our partnerships that we've gained through this pandemic, as Dr. Battle and Dr. Bayek talked about, and utilizing those to really address these underlying issues is going to be very important, so that, you know, when the next pandemic comes, they won't say, well, we knew about this then, but what did we do? No, they can say, we knew about this then, but here's what we've done in the interim to address this. And this is why, hopefully, we don't see the same, you know, disparities, you know, come whenever the next pandemic will be.
Yeah, and I think we need to do a better job with recruiting into healthcare diverse practitioners. I think we need to address the issues of unconscious bias in healthcare. We need to invest in, you know, systems of care, and we need to really ravel these issues of systemic racism. Where is it in our institutions? Where is it in the institution of healthcare? And addressing them and changing policies and practices that could that creates systems that, whether it's conscious or unconscious, they're there. We've got to break these things down and eliminate them, basically. And we've got to be more engaged, particularly, you know, for those of us that are in the communities that are already highly marginalized. And there's been a great amount of disinvestment and all of these things. We've got to leverage our ability to convene stakeholders and businesses and others to help build these communities up. We can't leave them the way that they are, because healthcare affects all of our lives, period. It can't be separated from who we are as human beings. And so we need to, but healthcare is not just biomedical care. It is wellness, and these communities need wellness. And as anchors to these communities, we've got to invest better, not just the healthcare system, but the businesses, public health, social services, you name it, into these communities to improve the overall health and the issues of health that help result in what we're seeing with this COVID vaccine.
Again, I'm going to agree with everything that Dr. Robinson and Brenda are saying. And I will add that we need to keep having the conversation, right? Be it with our trainees, our students, our friends, our community members, other researchers, you know, that the more we talk about it, the more it's sort of at the forefront that we need to address it, right? And so that's one thing. I think the other thing is, and as a researcher, I've been thinking about this a lot in terms of like different types of frameworks, is when we institute a policy or you design an intervention, we're always thinking about who is it going to help. But I actually think we also need to think about, well, who may it actually hurt, right? And I think having that mindset of it's going to help these folks, but oh, wait a minute, these folks may not have access to it. So am I going to make the disparity worse by actually implementing this policy or this intervention? So that is one thing personally I'm thinking about as I'm moving forward.
We have so many good questions that are coming in, and I want to get to as many as possible. So I'm going to open up this a little early and try to do a mix of quick questions and ones that are going to require a little more thought. But one is, what forms of address verification do you use to avoid excluding those who may not have their names on a lease, bills, or an official ID? So I think that's probably like more of a Protect Chicago or any, I think, Brenda, the work that you all are doing too.
Yeah. So I'll start it with, and then Dr. Robinson, we're doing it under the Protect Chicago umbrella. And so when persons call to register for their vaccine, we're asking for address verification. And when they come to the clinic, we're asking and checking for address verification too, because we're looking for folks in those communities that Protect Chicago Plus is intended to serve. So
yeah, it doesn't have to be, government forms of ID either. There are other ways to do kind of address verification. Of course, if you have a government ID, that you can use that, but letter, a postmarked letter, like you mentioned, bills or rent or utility, but sometimes people don't have that. Postmarked letter, other bills, pay stub, or some other thing that has, kind of your address on it are all used. So there's a whole list. And I think, as we get ready to go into the next phase of vaccination, Chicago clinics are going to also Chicago vaccination sites will also require some verification. There's a whole list. So we will be, if it's not already on the website, it will be on the website, but there are whole multiple ways that people can kind of verify that they are in the neighborhood so that we can be as inclusive of everyone in the neighborhood while also, walking that fine line between, excluding people in the neighborhood and, leaving it so lax that people from outside the neighborhood can come in.
How do you address vaccination needs of homeless individuals who have no address to prove they are in a focused zip code?
Yeah, so we actually have providers who work specifically with our homeless population, and we're addressing that by providing vaccine to those providers to use in the course of their normal activities at shelters, teams that go out and provide care out on the streets and things like that. We are actually, providing vaccine to those providers so that they can go to the populations and vaccinate them where they are, or where the homeless population may come into a shelter, et cetera. So that's really another area where that partnership with the providers who are already serving that community is very important.
So we have someone named, I hope I'm pronouncing it correctly, Dagmara Costco, Dagmara, who says, I am a UChicago alum, class of 2013. I started the bilingual volunteer organization Vaccinate Chicago. Our group seeks to help eligible community members, especially senior citizens, get vaccinated. As you know, the pandemic has shed light on current healthcare disparities and has taken a significant toll on minority communities. With this in mind, an effort to reduce barriers to access vaccinations that our group was created. So far, we've been able to schedule nearly 300 appointments for eligible individuals, such as senior citizens and individuals in our local medically underserved minority communities who struggle with access due to technological, language, and other barriers. Given our great success so far, we are eager to reach and help more people in these vulnerable communities. Would it be possible to connect with the panelists after this session to provide them with more information about our group and see if they could help us spread the word to reach more people in need?
Absolutely, yeah.
Yes.
And I don't know if, I think you all can put information in the chat, if that helps. So based on these lessons learned and knowledge that inequities existed long before COVID and will remain afterwards, how will more money and more power and more decision-making be shifted from city and private, like UFC investments, to grassroots community-based organizations led by and serving communities most impacted?
So yeah, the Department of Public Health also really seeks to kind of work with community-based organizations as well. And as we get funding, we're actually looking to partner with, and where we have funds available, work with some of these organizations as well. So it's definitely a partnership that public health is invested in, and certainly partnerships, as Dr. Battle mentioned, that we would love to continue and kind of keep going. It will absolutely be necessary to reaching community members and really going with the trusted people in the individuals in the community. So definitely it is something that is certainly worthy of investment in time and resources as we go forward.
And here is a rumor question. And Eileen says, I preface my question by acknowledging that my information may be incomplete and or inaccurate. Having said this, my understanding is that there are many short-term workers at the United Center vaccine site that are Black from Chicago. They haven't been given an opportunity to get the vaccine because they don't fit an age or health criteria. They are said to not be frontline workers, so they aren't able to use that criteria either. Can this be rectified? And I guess I would add to that, is that accurate?
I don't know that that is accurate, but we can certainly follow up. We have been kind of vaccinating, the people in our city pods, because they're working and interfacing with the community for vaccination. So we can certainly look into the accuracy of that.
So Mike says, okay, what is equity? Given that it may be likely that some groups are both reluctant, underserved, discriminated against, more at risk, or less healthy, et cetera. He's asking, 1, is it equal vaccine available per citizen or person in a group? 2, is it equal local availability? 3, equal vaccination per person in a group, or equal vaccination per risk factor? And I think I'll just tack on to that. I've seen some social media chatter that says, why are we even doing this? Just open it up to everybody and let's just do vaccines that way. So I'm not saying that's what Mike's question is, but he's asking what are those metrics, but there still are questions for some people, even though we're not seeing Black and brown communities get vaccinated more than white people. But if you could also just talk about why equity matters.
Well, I mean, I'll start with so when we determine equity, equal, we don't determine whether we should do an equal distribution across everybody, because there's some populations that are far more vulnerable to the effect that COVID can have on them than others. And so when we're thinking about equity, we're talking about getting to those populations who have a vulnerability that could potentially result in, a greater effect of COVID on them. And Black and brown, many persons in Black and brown communities that already suffer from disparities fit the criteria or the index for what's considered vulnerability. And it's not just health, it's a number of other factors that Dr. Robinson can talk about based upon Protect Chicago Plus and the vulnerability index that they're using. So that's what we're talking about. So we're not talking about equal distribution. Yeah, equal distribution has to do with people's resources and availability to get to vaccines, and includes transportation and a number of issues that allow people who are more resourced to quickly go out and get the vaccine, and leaving the rest of the population without the ability to get the vaccine at the same pace as others. So that's why equity is important. It will be the case that if there is supply, then the demand will be there for people who are better resourced to get it. But supply doesn't mean people who are not resourced to get it are still going to get it and their lives be saved as well. So equity is important to ensure that everybody has the fair and most optimal ability to get the vaccine based upon what their needs are. And so that's what we're trying to get to ensure that that happens. Otherwise, you're going to have mass resource folks, which we see now, resource folks going into vulnerable neighborhoods to get the vaccine because they can get to those vulnerable neighborhoods, whereas many vulnerable populations can't get to other neighborhoods to get the vaccine, nor will they be welcome in the neighborhood sometimes to get those vaccines. So that's what equity is about, and that's why it's important.
Yeah, and I'll add to that, right now, as Dr. Battle alluded to earlier, our supply is very limited. I wish we had enough vaccine to just put it everywhere simultaneously all at once, but we don't. And that's part of why, even CDC, as they made these recommendations for the vaccine, prioritize populations who were most vulnerable kind of first, because we are in a setting where our supply is limited and we don't just have supply to kind of just stand up huge operations kind of everywhere yet. And so while we're waiting for more supply, as Dr. Bagno mentioned, we really wanted to focus on, she talked about this earlier, outcomes for others affect us all. And so we really need to focus on kind of these areas where people are most vulnerable, where people have been highly impacted, where we've seen high rates of COVID illness, where we have communities that have higher rates of underlying conditions that, make getting COVID may make it more likely for them to have a serious outcome from it as well, which impacts our health system, which impacts a number of other things. So it's really about, while we're kind of in these phases of limited resources, using our resources where they make the most impact, because that's good for us all. That's not just good for that community, that's good for our city, that's good for our state. And so really using those factors to determine where our supply goes in these limited phases is very important for how big of an impact we can make on COVID, and as quickly as we can.
Maria has a question that I know that I have been wondering myself. How accurate are the stories about vaccines going to waste? I've heard people use that as justification for line jumping.
Yeah, we don't have, there are not many stories about vaccines going to waste here in the city of Chicago. At the end of the day, people really manage their vaccine supply well. That you can control how many vaccines you draw up and make ready for use. And if you don't draw that vaccine up and make it ready for use, that vaccine just goes back in the refrigerator or the freezer, and so that you can use it the next day. And when we have doses left over at the United Center or our city pods, we have mechanisms to use those doses so they don't go to waste. And, in forms of, if you had to put out extra appointments, et cetera. So that should not be, a justification for line jumping, because that is really, really rare. That we have kind of incidences of waste. There's no mass waste here. All the clinics have kind of these plans in place. So that is not accurate. So that is not the case.
And the other thing is, as healthcare providers getting the vaccine, we have to report to the CDPH what we're getting, who's getting it, what the diverse makeup is of people who are getting it. So, and we get vaccines according to what we give. And so there's no wasted vaccine. It is get the vaccine, get it in folks' arms, and then the city knows, because it's all reported, that what you've given, and you get your next supply based upon that. So we're in these regular meetings with those of us providers and community-based organizations that are getting vaccines into folks' arms. What we're crying to the city and basically wearing Candice and other folks out is that we need more vaccine. How can we get more vaccine? Because we need to give more, because we're having to cancel appointments and do things that put people off, and give them their second dose later, things that, because there's just not enough to give to the folks. So there's not wasted vaccine. That's not true.
Pamela asks, do the requirements of a pre-scheduled appointment contribute to the access challenges? Many essential workers do not have the flexibility to immediately schedule when slots open, and are not held at hours that complement our essential worker schedules. Any thought of walk-in clinics? Maybe Dr. Baig, maybe you can take that one.
Sure. I mean, I totally agree with that. I mean, it's the same thing for healthcare, right? So a lot of health centers actually have late evening hours and weekend hours, because they are serving patients who are working, maybe double shifts, have childcare obligations, so they can only come in the evenings and the weekends, and maybe in a drop-in fashion. So I think those lessons from what community health centers are doing is exactly what we need to be doing in terms of vaccinations too. It's a little bit challenging, again, because the vaccines are scarce. I think that's part of the problem. And also because you need 2 doses for these Pfizer and Moderna. Now with Johnson & Johnson, it's only 1 dose, so there may be more opportunity for drop-in, and again, this is as things are evolving, right? Our technology is evolving, the vaccines that we're seeing approved is evolving. Johnson & Johnson doesn't need the really cold refrigerator, it's only 1 dose. So I think as we are advancing in medicine, we're also able to advance and think about how to actually get people who need a drop-in place that they can come to. So I think that the person with the question is right on.
Here's an ethics question. Mike wants to know when a neighborhood, and I don't know if this is something that's happening, but when a neighborhood's specific venue appointments are not filling up, is it okay for people to come from other neighborhoods to fill up those slots?
So our community-based organizations certainly work closely with the Protect Chicago Plus provider in, filling those appointments and kind of, going to that community first, and then they make plans kind of from there. But honestly, we've had, thus far, really good success with the Protect Chicago Plus clinics, and that hasn't been a major issue thus far. So, it's something that we work very closely with those community-based organizations to really draw in the community and really get people signed up. Some of the clinics have different hours to kind of, account for their clinics that some neighborhoods, the clinics are on the weekend, really working with those organizations to find out what will work best for that community, so that we can kind of get that community, that temporary clinic really tailored for that community has really been a big part of Protect Chicago Plus. So we really work with the community-based organizations to really troubleshoot and address any sign up or other concerns that come up from the community.
What can the average person do to support Chicagoans in getting vaccinated? For example, assist with transportation, donations, anything else?
I would say one specific area of focus is we're really focusing on getting our seniors vaccinated. We're close to about 1 in 2 seniors over 65 in Chicago have been vaccinated to this point. If you know a senior, if you have a senior in your life and they're seeking vaccination, assist them. We really need our seniors, they can get appointments through call center, online for United Center. United Center recently had a drive-through option that opened up. So if you have a senior in your life, we're really still focusing on getting those seniors vaccinated because they have such a high risk of severe disease and bad outcomes from COVID. So I'd say that's one immediate area that, if you have seniors, if you have seniors in your life, assist them in getting their vaccination if they're having difficulties. And Dr. Battle, I know you're about to say something.
I was going to say, tell folks to get the vaccine. I mean, if you've got it, tell other folks, as many people in your life as possible to get it, because we do need to all have it. So I think that's important as we progress with this.
I have been doing Zoom for over a year now, and I've never had an event with this many questions. They are coming in even as I was answering. I'm sorry I couldn't get to every question, but these were really great, and I'm glad that I started it a little early so we could address rumors, we could address questions about why these issues matter, as well as some very practical questions that were in there. So thank you. And I'm going to turn it back over to Meredith.
Yeah, I think the number of questions are just reflective of the fact that we could probably have this conversation for 5 hours, because we could never really confront the entire history or really lay out the entire future of what needs to be done. I think Dr. Robinson and Brenda Battle both sort of talked about how there's a lot of work ahead of us even after this pandemic is over. So Natalie, Dr. Big, Dr. Robinson, Brenda, thank you so much for having this conversation, for taking questions, but most importantly, for the work that you do every day. These challenges aren't going to be solved overnight, but at least properly identifying them, talking to people within our community about what these challenges are, why they matter, and the small part we can play in trying to build a better future for our city and for our country is so important. So I'm so grateful for you for joining us. I'm grateful for all of the participants who both tuned in and shared questions. We'll be back on April 29th with a conversation about how racism is impacting public education, and then in May for a conversation on public safety. So I hope you all can come back and join us then. And again, thank you all so much for your work and your thoughts today. We really, really appreciate it.